Good afternoon, everyone. It's a real pleasure to be able to present to you, let me just get this on, South Africa's journey to where we are now at a point where we really want to work on integrated person-centered care in primary health care. I want to do acknowledgements up front. I want to acknowledge consultants that's provided to the department through Clinton Health Access Initiative, which we call CHI in South Africa for short. And so I'm using slides from Dr. Jackie Dunlop, Dr. Jeanette Wessels, and Dr. Sibongile Zungu. I've also taken data from macro trends, from Statistics South Africa's 2025 report on the mortality and causes of death in South Africa. Also used some UNICEF data and data from the WHO Global Tuberculosis Report 2024. The content of my presentation to you this afternoon is the South African context in general when it comes to health, the specific health system context. I give you a bit of background, the situation that we were faced with in 2010, because we started our continuous quality improvement turnaround in 2010. And that program is called the Ideal Clinic Realization and Maintenance Program. I tell you a little bit about it because there's a lot about the Ideal Clinic Realization and Maintenance Program. It is multiple lectures all on its own. I share with you key health outcomes that we've achieved over these the 10 to 15 years, and why we feel now more than ever there's a need and we can start working towards integrated person-centered care. I share with you what our challenges are in this regard and also the way forward for us. So the South African context as a country, you're looking at the whole of government with its different government departments. I'm starting at the top, at the biggest little circle. So there's South Africa with its government departments, the private sector, academia, NGOs and civil society, and that's the space within which we plan and deliver health services in South Africa. Then you've got South Africa's National Department of Health. Other countries on the African continent often talks about the health ministry, but we have a Department of Health with a minister heading it and a Deputy Director General, a Director General reporting to the minister running the department technically. We have 9 provinces in South Africa and therefore 9 provincial departments of health. We have 52 districts and therefore 52 district health systems. And it's within these districts that you find our primary health care facilities, which are fixed clinics, community health centers, and we also complement access with mobile vehicles and mobile services. And of course, to run this, the services within our primary healthcare facilities, we have different methodologies and systems. You need your human resources. You need a service package that is assisted by medication and equipment. And you need your service platform, which is your physical and other infrastructure. And then you have the facility management and staff. So to get even more specific, if you look at this diagram, the darker blue ellipse in the center is labeled primary health care facilities, which should be rendering quality, comprehensive, person-centered care. And the primary health care facilities is within your district health system. You look at the rectangle on the left, it says district health system, which must be characterized by good governance, leadership, and management. And then within that cosmos of the district health system, you need the primary health care facility to be supported by school health services. If I start there at between 10 and 11 o'clock and move anti-clockwise, you have your school health services, you have your district clinical specialist teams, which supports the services within the district on a clinical level, focusing especially on the health of mothers and children, on TB and on HIV and some key non-communicable diseases, because those are our main contributors to our disease burden in South Africa. You need your ward-based outreach teams, which is made up of community health workers. The clinic needs to be supported by NGO services. It needs to run health campaigns. It needs to be supported and communicate and liaise with environmental health services. You could also have some contracted service providers, because we don't in-source everything in South Africa. It also needs to be supported by social and psychological services. And if you look at the bottom of this ellipse, the word community is written in bold, because it means you need to work with your community. You need to know your community's epidemiology, the demographics of the community, and the community has to provide input into the services that you provide in your primary healthcare facilities. Then if you look at these orangey rectangles, blocks on the outside of the district health system, it speaks to the kinds of services that you need support from and you need to communicate with outside of the district health system. If I start at 11 o'clock again and move clockwise, you see we're talking about specialist hospital care for TB, multi-drug resistant TB control, for example. You need to be able to refer to specialized mental health facilities. You need your specialist non-communicable disease care. You need care for emergencies, obstetrics care, surgery. You need to be able to work with training institutions like universities, some NGOs, research institutions. You need to have a relationship with different research institutions to support research in this area, but also sometimes maybe to commission research for questions that you need answered. And then, of course, you need your, if we move right around to around 7 o'clock, you have to have a relationship with diagnostic services. So I want to give you the background of where we were as a country in 2010. Because in 2010, government made a decision to intensify its efforts towards universal health coverage, envisaging that we will finance our universal health coverage through the National Health Insurance. The next bullet speaks to the World Health Report 2010's definition of universal health coverage, where they say the aim of universal health coverage is to provide all people with access to needed health services of sufficient quality to be effective and to ensure that the use of these services does not expose the user to financial hardship. So I want to use this diagram to talk a little bit more about that, about universal health coverage and where we were at in 2010 in terms of those three salient features of universal health coverage. In terms of equitable access, South Africa started in 1994 when we became a democracy, when the country's government was started, to focus on building primary healthcare clinics where people live. And in one of its key policy papers that we started out with in 1994, when we became a democracy, was a target that we should have a clinic within 5-kilometer radius of every community. And yes, those services will also be complemented by mobile clinics, because 5 kilometers is still a long way for people to go. And we will also increase access through outreach services like the school health services and like our community health worker services. I want to jump to the third one, finance, just to say the country then started working towards its national health insurance policy, which in essence is a policy of pooling funds and being able through the pooled funds to buy services on behalf of South Africans, so that the services are free at the point of care. So I come to the middle feature, quality, the one I have in the middle, because that was the difficult one. And we were looking at quality in terms of infrastructure, whether facilities are staffed well enough to provide the services in a responsive manner, whether the staff are capacitated through training, do they follow, are clinical protocols available, do they follow those clinical protocols, do they have the equipment they need, the medicine, is the information management to ensure continuity of care, and also an audit trail, and are the correct admin processes to support the delivery of clinical services really present. And that quality facet was a problem to us because we did a survey of all the primary healthcare clinics in the country, clinics and community health centers. There were about 3,400 of them at the time. We did an audit and found that not a single primary healthcare facility passed the set quality standards in terms of the infrastructure, staffing, training, clinical protocols, equipment, medicines, information management, and other measures, you know, patient satisfaction, and so on. And that situation was not only problematic to the clients we want to serve, but it was also problematic to the staff. It caused frustration and burnout among staff because the clinics were short-staffed. Infrastructure was very bad. We had leaking roofs, poor supply of water and electricity to the facilities, gaps in medicine availability, and the lack of the equipment that they really needed. And so this slide, same diagram, but it communicates where we were in 2010. And I've gone into that while talking to the previous slide to say equitable access was not that much of a problem in 2010. Still don't is in terms of the facilities being there to be accessed, because there was a drive since 1994 to build clinics and restore clinics and get mobile clinics out there. And in 2010, the drafting of the NHI started, but the quality was very poor. And the reason for this is that since the late 90s, 1998, 1999, but especially around the year 2000 and early 2000, our health facilities, clinics and hospitals were simply flooded by people very sick with AIDS, HIV, positive persons being very sick, and the health system was simply overwhelmed. We had not started at that stage a treatment program yet, and that made it worse in terms of people getting very sick, people needing care, and clinicians losing patients because we didn't have a treatment program. And by 2010, you could see how the health system had suffered through the fact that 90% of time was spent on combating people sick because of HIV, managing people with HIV. I want to give you examples. The picture on the top left is a tent, and not even a good tent at that. And this was supposed to be a clinic. This tent building was supposed to be a clinic in a town called Lusikisiki. And at the bottom of it, you could see the toilet. I put it in inverted commas, that people were supposed to use. And in 2010, we then started the turnaround to move from the picture on the left to the picture on the right. In the top, you see an aerial view of what the tent clinic had become. Built a proper, well-functioning clinic with toilets inside and working toilets. The picture at the bottom, I must just say, was taken a few days before the clinic was officially open, so that is an artisan working there. We didn't take a picture of someone using the toilet. This is a toilet in another clinic, and it just says so much, guys. If you don't just look at the state of the toilet, but the communication on the door, someone just took a cokie and wrote, "Do not enter." Then they scratched through it, I suppose, when it works for a little bit. Then someone wrote, "Toilet not working." Then they had to scratch through it. Then write, "No entry," and scratch through it. And then at the bottom is written, "Is working." And I think finally they just decided to stack some stuff on it to really show that it's not working. But we did manage to, in the 15 years, move facilities like this picture on the left to the picture on the right, where you have a solid building with proper amenities, benches for people to sit on. What the 2010 audit also found, amongst a lot of other weaknesses, is that many of our facilities hardly had any space for people to sit while they are waiting for services. So in 2010, we started planning for this continuous quality improvement framework, which we ended up calling the Ideal Clinic Realization and Maintenance Program, because we realized right from the start, this is not like a flash, this cannot be a flash in the pan initiative. We need to build maintenance into it from the start, and therefore it became part of the title of the CQI framework. And today we call it for short ICRM. In the meantime, this Ideal Clinic Realization and Maintenance Framework grew into an Ideal Health Facility Realization and Maintenance Framework to include hospitals, because at some stage clinicians from hospitals were saying to us, "But now clinics are better equipped. Clinics have functional dental chairs, and our hospitals don't have functional dental cares. We need the framework to be adapted and adopted by hospitals as well." And there are many facets to this CQI framework, and as I said, that's a topic for many, many different lectures, or a week or long more lecture. But a key feature of the Ideal Clinic and Realization, the Ideal Clinic Realization and Maintenance model, is the integrated clinical services model, where we started realizing that we must stop treating disease, caring for disease in our clinics, but caring for people. People who have conditions related to hypertension, people who have conditions related to metabolic problems like diabetes, people have mental illnesses. There may be people who need to be assisted with early diagnosis of cancer and so on. And then, of course, you have the HIV and the TB. But HIV and TB was, and still is today, was very hard to dislodge from the vertical mode, because HIV was funded externally, not fully, but got a great deal of funding externally, from the PEPFAR fund, the American money. And TB was around 2005, 6, 7, 8, very clearly linked to HIV. It was hard to get, like I say, to dislodge those two programs from the vertical model. But what we did, now let me go back here, if I get to the busy slide, to say we reorganized the facilities to have 3 streams. A stream for preventative health, and that would be reproductive health and the well baby clinics. That included the immunizations that kids have to have. We had a curative stream for minor ailments, and then we had a chronic stream where people were consulted in one consulting room, and it's still like that today, for whatever chronic condition they have. Diabetes, hypertension, HIV, TB, and mental health. But on a that was in the clinic, but on a programmatic level, TB and HIV remained vertical until the funding cut in January 2025. And as I'll explain to you later, that is why, South Africa moving formally to better care coordination and real integration became very important. So the Ideal Clinic framework has 10 components. I'm not going to read through them here because I'm sure this will be shared with you. And under the 10 components, you have 33 subcomponents. And the subcomponents each have a number of elements. We are at 280 elements. I did share with the organizers of this session the link to our Ideal Clinic website. And when you go to the website, you'll get a pretty good idea of what it's about. But this picture here, bottom right, is the front page of our manual. Not only did we have to specify through the framework exactly what needs to be present in the facility under these 10 components and under the 33 subcomponents, but we wrote this manual to describe exactly how you get to fix it when it's not present in your facility. Define the element and then give a description of what a staff member within a primary healthcare facility has to do to get that particular element functional. This is a graphic from the early days when we were very anxious to see if the program is working. And this is a specific clinic called Katie Motabatsi Clinic. It's a clinic named after one of our political leaders in the country, erstwhile political leaders. And you'll see when we started measuring what is happening in this facility in terms of the elements that it requires to be an ideal clinic, only 41% of the required elements were present. Therefore, you see that 41% green. 18% was totally absent. 27% were there but not functioning very well. And then 14% of the elements were not applicable in terms of the service package of this particular clinic. And as you look over time, how the picture changed, we often didn't focus much on the green, but you really wanted to move the red into orange. And then with time, get the orange to be green. We realized that this is not going to happen overnight. Clinics that's been run down over more than a decade was not going to be fixed overnight because the program also didn't come with a huge budget. We had to continue to work within what was available within the district health system of South Africa and available for facilities to improve the quality at the facilities. So you'll see September 13, the 41% had moved to 49%, the 18% of missing elements had reduced to only 12%, and then the orange was 12%. And so much so that in 7 months, if you look at February 14, the last column on the right, that clinic had scored 82% green in terms of having all the elements that it requires to be a well-functioning facility. 8% of the elements were still not there. 8% were there but half functioning, and we had reduced the not applicable to 2%, because as a clinic's condition improves, it can also start to offer more and more services. The framework also has a grading in terms of having essential items, which every facility needs to have, and those are things like oxygen, an emergency trolley, an AED, and so on. So you have essential items, you have the vital items are the most important ones, then you have essential items, and then you have your important items. This is a snapshot of about 11 areas, and you can also see between 2015 to 2017 how it has improved. For example, signage and notices moved from 44% to 72%, and right at the bottom you see that for patient waiting times, it moved from the fact that 60% of people experienced a waiting time within the definition of what is acceptable. It moved to 72%, and so on. Can you see number 9? Clinical guidelines and protocols actually retrogressed because when the clinic scored 82%, and those clinical guidelines and protocols were actually scrutinized, it was found that many of them were not up to date and applicable, and their score came down until such time that those clinical guidelines that were inappropriate were replaced by the proper ones. So yes, and from time to time you find sticky areas, and especially the areas that relate to supply chain management was typically very, very sticky. But these kinds of evaluations had showed us that the program has worked. And this is a program today in South Africa that everyone has embraced, the unions, politicians, because it's very transparent. It is defined in the most simplest terms, and everyone understands it, and people are committed to the fact that their clinics needs to be turned into ideal clinics or remain as ideal clinics once it has been turned into an ideal clinic. This shows progress over time. If you look at the first column has got the names of the provinces, the second column has got the facilities, the third column has got our first year of implementation performance, because it took us all this time to plan, test, replan, re-implement to really start the program off on scale. So you will see that from 0% in the first year, we got 9.3% of the facilities to comply. After that, it moved to 55%, and so on. And at the end of 24-25 financial year, we had 80% of our clinics complying with standards. Here, I just want to share in terms of access in South Africa, to say that we build beautiful, well-functioning clinics, not just in urban areas. The clinic of Lusikisiki, which I showed you the aerial view earlier, was built for this community. One of the most rural communities you can find in the country has gotten a facility like this. So I want to move from my discussion up to now was completely about the service platform. It was about infrastructure, physical infrastructure. It was about medicines availability, improving medicines availability, availability of required equipment, protocols, administrative processes, to give patients a better experience when they visit our facilities, but also to give staff a wow experience to be able to work in well-functioning facilities. So, but we're not doing it for the sake of doing it. You are doing it so that we can make a proper impact on our burden of disease. And so with all this work on our service platform, how are we doing in terms of our burden of disease? These are the main contributors of our burden of disease. South Africa usually talks about the quadruple burden of HIV and HIV, TB, and other sexually transmitted conditions, maternal, child and women's health, the key non-communicable diseases, and then fourthly, violence and injury. But on this slide, I get a bit more specific to share with you the specific conditions that we prioritize as diabetes, conditions related to hypertension, conditions relating to mothers, children, and women's health. We also have men's health services, but they mostly fall under the areas of reproductive health, and they manage within the HIV, TB, and STI services. We prioritize conditions relating to lower respiratory tract infection, mental health, and then the different cancers. The reason why I have maternal, child, and women's health and HIV, TB, and STI in darker green bars is because the country significantly invested in these two areas in terms of resources, because we were losing a lot of South Africans due to HIV and TB. But also, it's not acceptable when you have a high maternal death rate, a high under 5 child death rate. And those are areas that needed attention. And therefore, we invested quite heavily in those two areas, unfortunately, at the cost of the NCDs. This is just a slide to show you signage with regard to those three service areas: maternal, child, and women's health, which is our preventative services, your curative services, and your chronic services. And I spoke to the fact that we reorganized the services. The second bullet, adult primary care, is a program we use in South Africa to train clinicians, nurses, and doctors, and other clinicians in terms of managing patients at primary healthcare level. We developed a primary healthcare equipment catalog, and we zoomed in on the availability of medicines. We have a chronic dispensing medicine program where you give medication for multi-months to assist with compliance. Then we have a vibrant school health services, our community health program. Just at the end of last year, we adopted our community health workers formally into the health system. They are now salaried workers. They no more function on stipends. And then, of course, our environmental health services. But to continue with our burden of disease, if you look at the maternal mortality, you can see over that period when HIV was on the increase and without really a proper treatment regime in South Africa, how maternal mortality increased and how we seem to be stabilizing it now. You'll just see for 2021 it spiked, and that was the period of COVID. This is our under 5 mortality. Again, the bump of deaths there coincides with a period of rapid increase in HIV, and we also more or less stabilizing it. It's not good enough yet. We are striving to bring the under 5 mortality down even more. Tuberculosis is very impressive. From 2000, the incidence has come down by almost 60%. This is really a success story. We also very quickly sorted out in South Africa extreme resistant TB. We still have resistant TB, but we had sorted out extreme resistant TB. This is our HIV trend, where you see the increase, and you see how this increase in HIV has affected other conditions like our maternal health, child health, and then also the TB. But this is the slide. This slide prompted me to put the HIV, TB, and maternal health in the bold green. Because of the investment, you can see the result. The orange line, you can see is TB. You see how it's come down. The pink line is HIV. You can see how it's come down. But then you can see in 2020, the biggest cause of mortality was COVID. But after COVID, it's become diabetes mellitus. And then green, you see cerebrovascular diseases, and the yellow line, hypertensive disease. And it is us in South Africa, within South Africa's health system, faced with this picture that makes us realize we cannot manage programs in silos anymore. We cannot manage people according to diseases, because many of these are comorbidities in the same person, and we have to move to better care coordination for integrated person-centered care. We use person-centered care very consciously, but we recognize that on a public health scale, you need people-centered care. But if you really want to make sure you care for people properly clinically, from visit to visit or from encounter to encounter with the health system, to make sure that people understand their condition, they become committed to comply to the treatment and management regime for their condition, so that they either return to good health or they are maintained well in terms of a diagnosis. You have to become person-centered. So what we are saying with this slide, that we have a country and health systems context, and within that context, you have patient and community characteristics which you have to know. And then there's the health facility characteristics. That's either positive or negative, and when they're positive, you have to maintain them as positive, and if they're negative, you have to do something about it. Because that health facility characteristics is going to impact on your patient's experience of care. And if your patient doesn't have a good experience, you will not, as a health system, have positive health outcomes. And so in this journey towards better care coordination for improved integrated person-centered care, we looked carefully at what our problem is at the moment. And we are saying that despite strong policy intent, health services remain fragmented due to vertical program design, siloed financing, parallel systems, and misaligned accountability arrangements. And this results in discontinuous care, people falling out of care, coming back only when they're very ill, and as soon as you get them to feel better, they fall out again. And we won't win in terms of our burden of disease, especially the now increasing burden due to non-communicable diseases if this continues. And we need to reorientate our health system according to the WHO's building blocks. We need to set up an environment that will support the reforms that we are planning. to be able to have an outcome-driven primary health care, which means we broadly, we are people-centered. You move to what's good for the greater part of the community, but you have to have a relationship, keep your eye on individual patients, their care, make sure that is the best in terms of the conditions that they have. And then, and everything has to be evidence-informed and data-driven. Government-led but nationally owned. We'd like everyone to buy in to better care coordination for improved integrated person care. And although it's government-led, we recognize we have to work with private sector, we have to work with academia, and we welcome that with the NGO sector and also with civil society, and that's the only way we'll be able to adapt and remain resilient. And if I haven't mentioned it enough, or at all maybe, I have to pause and say we do have a strong focus on prevention and disease prevention and health promotion. And we have strong programs, community-based programs, in terms of health promotion and disease prevention as well. So, defining South Africa's integrated patient centered care framework is that if I start at the bottom here with this vertical block in green, we are saying it's based on a holistic understanding of the individual's health needs, well-being capabilities, self-management, preferences, and context. In other words, the environment in which they find themselves. You need to understand that in terms of the individual, in terms of caregivers if they have, and other family members. And we have to make every contact count to get to know the person better and how we can serve the person better, but also make every contact count for the person to become more informed about their condition, whether they are 100% healthy. So how do you keep yourself healthy, or whatever condition you have, how do I curb the condition not to progress? And how do I, if possible, return back to good health? So we work for that individual person that becomes part of a people-centered health environment in South Africa. What are we going to do? We must have the correct package, the full comprehensive package of services. And when along every life stage, starting in utero and moving on to right through the life course to the older person, and where in our communities, with our community-based services, in our primary healthcare facilities, and moving on to hospitals, because unfortunately you can't care for everyone at the primary healthcare level. And so we are aiming for coordination throughout that course. So ultimately, this is our vision, to have this kind of service platform and structure that works well for patients and staff, so that you have well-functioning, if I start on the left with the ellipse on the left at the top, community-based services, comprising of community health worker services, school health services, environmental health, where a patient can then, if necessary, move on to clinical services within health facilities, that those clinical services within health facilities are well supported by diagnostic and paraclinical services, strong and good medicine supply, and you have the emergency medical services being responsive when you need them. Of course, you need a good referral system to support that, and your implementation enablers. Our administrative processes are so important in terms of giving good quality clinical care. You need good financial management and supply chain management. You need good human resource management, legal services support, good infrastructure, information management, security services are very important in South Africa. Everything must be done with community participation, and without good management, leadership, and governance, you'll have nothing. Of course, if I move to the vertical bars on the right, capacity building, capacity building, capacity building, same with communication, and then collaboration with all necessary stakeholders if we are going to improve in terms of achieving universal health coverage. The challenges that we have is that we do not have complete multidisciplinary teams. We grow these teams as budget becomes available, but also sometimes you can't get all the skills, especially in rural areas. And it's something we have to work on in terms of training more people even in specialist areas. And then a key weakness in South Africa is our lack of an electronic patient record, because this interrupts care, it doesn't lend to continuity of care. And in other words, we lack the information to care holistically for people. So the way forward, we are working with Clinton Health Access Initiative, CHI, at the moment, and we is talking about the National Department of Health South Africa, as well as with the World Health Organization. And in fact, we have a World Health Organization consultant working with us right now to complete our care coordination for integrated patient care framework, to complete it and to cost it. And we will use this document to incrementally obtain the required funding to do better in this space. Thank you so much. Thanks for listening.